Hello everyone, and welcome back to the channel. Today we're going to cover one of the most fundamental and important topics in pharmacology, pharmacokinetics. Pharmacokinetics describes what the body does to a drug. It explains how quickly a drug begins to work, how intense its effect will be, and how long it remains in the body. We summarize pharmacokinetics using four key processes, collectively known as ATME. A. Absorption, which is how the drug enters the bloodstream. D. Distribution, which is how the drug moves throughout the body. M. Metabolism, which is how the drug is chemically modified. E. Elimination, which is how the drug is removed from the body. Let us begin with the first step, absorption. Absorption refers to the movement of a drug from its site of administration into the systemic circulation. For a drug to be absorbed effectively, it must be given via an appropriate route of administration. The choice of route depends on the desired speed of onset, duration of action, and whether the intended effect is local or systemic. Routes of administration are broadly divided into enteral, parenteral, and other specialized routes. First, let us discuss enteral routes, which use the gastrointestinal tract. The oral route is the most common and convenient enteral route. Most orally administered drugs are absorbed primarily in the small intestine due to its large surface area and rich blood supply. However, oral administration has several disadvantages. Drugs may be destroyed by gastric acid, degraded by digestive enzymes, or undergo first-pass metabolism in the liver. First-pass metabolism refers to the hepatic metabolism of a drug after oral absorption and before it reaches the systemic circulation, leading to reduced bioavailability, which reduces the amount of active drug reaching systemic circulation. To overcome these limitations, special oral formulations are used. Enteric-coated tablets protect drugs from stomach acid and dissolve in the intestine. Intravenous IV administration delivers the drug directly into the bloodstream. It produces an immediate effect and has 100% bioavailability. Intramuscular injection delivers the drug into muscle, resulting in moderate absorption. Certain formulations, known as depot injections, release the drug slowly over time. Subcutaneous SC injection delivers the drug under the skin and provides slow, sustained absorption. Intradermal ID injection delivers the drug into the skin and is mainly used for diagnostic and immunologic testing. Other routes of administration include inhalation, which allows very rapid absorption through the lungs. Intrathecal administration, which delivers drugs directly into the central nervous system. Topical administration, used for local effects on the skin. Transdermal patches, which provide long-term systemic drug delivery through the skin. Now let's return to absorption mechanisms. Absorption occurs through several mechanisms. Passive diffusion is the most common mechanism. Drugs move from an area of high concentration to low concentration without energy consumption. This mechanism favors lipid-soluble, non-ionized drugs. Water-soluble drugs may also cross membranes through aqueous channels by passive diffusion. Facilitated diffusion also moves drugs down a concentration gradient and does not require energy, but it uses carrier proteins. This process is saturable, meaning that once all carriers are occupied, absorption cannot increase further. Active transport requires energy and moves drugs against a concentration gradient, from low concentration to high concentration. Like facilitated diffusion, it is carrier-mediated and saturable. Endocytosis is used for very large molecules such as vitamin B12 and involves engulfment of the substance by the cell membrane. Finally, several factors influence drug absorption. pH and pKa are critical because only the non-ionized form of a drug crosses biological membranes easily. Blood flow affects absorption. Greater blood flow enhances absorption. Surface area is extremely important. The small intestine has a much larger surface area than the stomach, which is why most drugs are absorbed in the intestine. Contact time also matters. Rapid gastrointestinal motility reduces absorption. Finally, P-glycoprotein transporters actively pump certain drugs out of intestinal cells, reducing absorption and bioavailability. Bioavailability is defined as the fraction of the administered dose that reaches the bloodstream in an unchanged active form. Intravenous administration has a bioavailability of 100% because the drug is delivered directly into the circulation. In contrast, orally administered drugs usually have lower bioavailability due to incomplete absorption and first-pass metabolism, where the drug is metabolized in the liver before reaching systemic circulation. Bioavailability is measured using the area under the plasma concentration time curve, or AUC. Drugs are considered bioequivalent when they have similar AUC, peak concentration, and time to peak concentration. Therapeutic equivalence requires bioequivalence as well as the same dose, route of administration, and clinical effect. Next, we move to distribution. Distribution refers to the reversible movement of a drug from the bloodstream into body tissues and fluids. One of the most important factors affecting distribution is blood flow. Organs with high perfusion, such as the brain, liver, kidneys, and heart, receive drugs first. Poorly perfused tissues, such as fat and bone, receive drugs more slowly. Certain physiological barriers also influence distribution, particularly the blood-brain barrier, which limits drug entry into the central nervous system. Only lipid-soluble drugs or drugs with specific transport mechanisms can cross this barrier effectively. Another critical factor is protein binding. Many drugs bind to plasma proteins, mainly albumin. Only the free, unbound fraction of a drug is pharmacologically active and capable of producing a therapeutic effect. Protein-bound drug acts as a reservoir, prolonging drug presence in the bloodstream. Changes in protein binding can significantly affect drug activity and toxicity. Lipophilicity also plays an important role. Lipid-soluble drugs distribute widely into tissues and may accumulate in fat. Additionally, tissue binding can prolong drug action, but may also increase the risk of toxicity due to drug accumulation. Now let's discuss the volume of distribution. The volume of distribution is a theoretical parameter that indicates how extensively a drug distributes throughout the body. A low volume of distribution suggests the drug remains primarily in the bloodstream. A moderate volume indicates distribution into extracellular fluid. A high volume of distribution means the drug is extensively stored in tissues. Drugs with a large volume of distribution often have a longer half-life and prolonged duration of action because they slowly redistribute back into the plasma for elimination. Next, we move to metabolism. Drug metabolism, or biotransformation, occurs mainly in the liver and converts lipophilic drugs into more water-soluble compounds to facilitate excretion. Most drugs follow first-order kinetics, meaning a constant fraction of the drug is eliminated per unit time. However, some drugs follow zero-order kinetics, where a constant amount is eliminated regardless of concentration. Classic examples of zero-order kinetics include ethanol and phenytoin at high doses. Drug metabolism occurs in two main phases. Phase 1 reactions include oxidation, reduction, and hydrolysis. These reactions are primarily mediated by the cytochrome P450 enzyme system in the liver. Phase 1 metabolism often produces metabolites that may remain pharmacologically active or in some cases become toxic. Rather than making drugs fully water-soluble, Phase 1 reactions usually prepare them for further modification. Phase 2 reactions involve conjugation, where the drug or its Phase 1 metabolite is linked to an endogenous substance such as glucuronic acid, sulfate, or glycine. This process produces compounds that are highly water-soluble, usually inactive, and easily excreted in urine or bile. The cytochrome P450 system is clinically very important. Major enzymes include CYP3A4, CYP2D6, CYP2C9, and CYP2C19. Genetic variations in these enzymes explain why individuals may respond differently to the same drug, showing differences in efficacy or risk of toxicity. Enzyme inducers increase cytochrome P450 enzyme activity or expression. This leads to faster drug metabolism, reduced plasma drug concentrations, and potentially decreased therapeutic effect. Enzyme induction develops gradually over days to weeks because it requires new enzyme synthesis. Common enzyme inducers include rifampin, carbamazepine, phenytoin, phenobarbital, and St. John's wort. In contrast, enzyme inhibitors decrease cytochrome P450 enzyme activity, slowing drug metabolism. This results in higher plasma drug levels and an increased risk of toxicity. Enzyme inhibition occurs rapidly, often within hours to days. Common enzyme inhibitors include macrolide antibiotics, azole antifungals, protease inhibitors, cimetidine, and grapefruit juice. Now we move to excretion. Excretion is the process by which drugs are removed from the body. The kidneys are the primary route of elimination. Renal excretion involves three main processes: glomerular filtration, tubular secretion, and tubular reabsorption. Ion trapping is an important concept in renal drug excretion. Only the non-ionized form of a drug can cross biological membranes. When a drug becomes ionized, it is unable to diffuse back into the bloodstream and becomes trapped, leading to increased excretion. Weak acids are more ionized in alkaline urine, which enhances their elimination. Weak bases are more ionized in acidic urine, also increasing their excretion. To give you an example, aspirin is a weak acid. Alkalinizing the urine, e.g. with sodium bicarbonate, enhances aspirin excretion in cases of overdose. This principle is clinically important in drug overdose management and explains drug accumulation in compartments such as breast milk. Next, let's discuss clearance and half-life. Clearance is defined as the volume of plasma cleared of drug per unit time and reflects the efficiency of drug elimination. Half-life is the time required for the plasma drug concentration to decrease by 50%. Both clearance and half-life are influenced by kidney disease, liver disease, age, and drug-drug interactions. Now let us discuss steady state. Steady state occurs when the rate of drug administration equals the rate of elimination, resulting in stable plasma drug concentrations. A key principle is that steady state is achieved after approximately 4 to 5 half-lives and depends on clearance, not dose size. There are two main dosing strategies. A maintenance dose maintains drug levels within the therapeutic range. A loading dose rapidly achieves therapeutic concentrations, especially for drugs with long half-lives, but carries a higher risk of toxicity.